also here.
Start करें Dr. Naveed?
Kashif, I'll start with introductions and then I'll give it to you.
Yeah.
Sure. First of all, thank you, Dr. Naveed. Yes, Dr. Naveed ने मुझे ये एक opportunity दिया that I can present the antibiotic stewardship. What are the basics? What are the principles? And how to implement antibiotic stewardship in any facility. My name is Kashif Hussain. Currently, I'm working as a manager in Department of Pharmacy. I've done my PharmD, MPhil, and now I'm doing my PhD in pharmacology. And I also did my certification course from Society of Infectious Disease Pharmacists, which is an online course, 1-year course from University of Virginia. Okay. Now officially, I think now my stuff. So this is disclosure statement. I do not have any financial relationship with proprietary, producing, marketing, reselling. अच्छा मेरा जो है antibiotic अच्छा Dr. Naveed, I will speak in both English and Urdu. Will it be okay?
जी बिल्कुल, you can speak in Urdu as well. That's fine.
ठीक है ना? Okay, fine. मेरा इंटरेस्ट शुरू से जो है एंटीबायोटिक्स में इस तरह रहा कि आई जॉइन में आगा खान हॉस्पिटल इन बैक इन 2001 एंड 2002. तो वहाँ पर शुरू से मुझे आईसीयू के राउंड्स पे जो है वो डिप्यूट कर दिया गया. वहाँ पर एंड यू नो द क्रिटिकल केयर में सबसे ज़्यादा जो ड्रग्स इस्तेमाल होती है वो एंटी माइक्रोबियल इस्तेमाल होती है. तो वहाँ पर शुरू से मेरा इंटर जो है आईटी फिजिशियन के साथ रहा और फिर जो हमारा पीआईसी भी वहाँ पे स्टार्ट हुआ. देन डॉक्टर अनवर ने आगा खान ज्वाइन किया. फिर डॉक्टर अनवर के साथ हमने जो है पायलट किया. उसके बाद जो है हमने अपने सर्जिकल आईसीयू में एक पायलट किया. उसके बाद हमने अपनी फैसिलिटी के अंदर इसको एंटीबायोटिक स्टीवर्डशिप को जो है ऑफिशियली 2018 के अंदर स्टार्ट किया. लेकिन हमारे हॉस्पिटल के अंदर जो है एंटीबायोटिक सब कमेटी वाज फॉर्म्ड इन बैक इन 2000. तो हमारे हॉस्पिटल के अंदर अगर मैं बात करूँ तो हमारे पास स्टीवर्डशिप का जो है वो बैकग्राउंड था फॉर लास्ट 15-16 years. लेकिन वो ऑफिशियली इसको नाम हमने we did not give the name of antibiotic stewardship. ठीक है ना? आजकल हम काफी बात करते हैं antibiotic stewardship, लेकिन stewardship है क्या? You know, steward means is a captain, कप्तान. Ship is ship, जहाज. इस जहाज का कप्तान कौन है? ठीक है, तो जहाज किसका है? जहाज एंटीबायोटिक का है. उसका स्टीवर्ड कौन होगा? उसका स्टीवर्ड फिजिशियन भी हो सकता है, उसका स्टीवर्ड जो है फार्मासिस्ट भी हो सकता है. लेकिन अगर वो फिजिशियन इन्फेक्शियस डिजीज का होगा या द फिजिशियन who have a knowledge of infectious disease, then it will be much better. The pharmacist who is trained in infectious disease will be much better rather than the pharmacist. There are different fields of pharmacy, like clinical pharmacist के different roles होते हैं. अगर वो clinical pharmacist infectious disease के अंदर train होगा, then it will be much better. होता है. ठीक है. So I just want to give the background. Okay, all drugs have the adverse drug effect, लेकिन antimicrobials के some have some additional effects, and these are known as collateral damage. There are if you are seeing the these 4 figures, 4 icons. First, there are lots of jumps, लेकिन इसमें just a couple of them are drug resistant. But when you start taking antibiotics unnecessarily, and antibiotics kills the bacteria which are causing the illness as well as the good bacteria which are important for us, normal flora. As a result, the drug-resistant bacteria जो है वो आहिस्ता-आहिस्ता अपना चार्ज लेते रहेंगे और in the end वो अपना रेजिस्टेंस जो है वो ट्रांसफर करते रहेंगे. CDC का एक डेटा था कि जी अराउंड 2020 के अंदर 40 to 50% of antimicrobials used in US are inappropriate. 40 to 50% use of antimicrobials in US is inappropriate. So we can imagine that this inappropriateness can be, I think, 60% at least in developing countries like Pakistan. About 23,000 deaths and 2 million illnesses yearly in US, while 25,000 people in Europe and more than 700,000 deaths reported in Asia, Africa due to antimicrobial resistance. Why do we do? Why मतलब antibiotic का डेवलपमेंट भी जो है हमारे पास इतना ज़्यादा नहीं है जितनी तेजी से रेजिस्टेंस स्प्रेड हो रहा है. As we can see from this graph, in 2008 till 2012, only we have couple of antimicrobials which came into the market. I was reviewing the essential drug list of our hospital, and surprisingly मुझे ये पता चला कि हमारी drug list के अंदर 2020 के अंदर वो ड्रग्स भी शामिल हैं जो कि अभी तक हमारी मार्केट के अंदर आई ही नहीं है, लाइक सेफ्टोसिडीम एविबैक्टम, मेरोपेनम स्लैश वोबैरबैक्टम, सेफ्टोलोजोन टेजोबैक्टम, जो कि अभी रेजिस्टेंस को ओवरकम करने के लिए यूएस के अंदर लॉन्च हुई हैं. वो ड्रग्स हमारी एसेंशियल ड्रग लिस्ट में तो हैं हमारे पाकिस्तान के, लेकिन वो ड्रग्स अभी तक पाकिस्तान में रजिस्टर्ड नहीं है. तो हमारे पास एक लास्ट रिजॉर्ट क्या रह गया है? लास्ट हमारे पास एक कॉलिस्टिन रह गया है, टिगिसाइक्लिन रह गया है, फॉस्फोमाइसिन रह गया. फॉस्फोमाइसिन आईवी भी मैन्युफैक्चरर ने बनाना छोड़ दिया है. So we can imagine now we have only couple of weapons to overcome this antimicrobial resistance, like tigecycline, colistin. So what is the solution to overcome the emergence of resistance? So there's a program which is known as Antibiotic Stewardship program, which creates a balance between the appropriately treating the patient and avoiding the selection of antibiotic resistant organisms. There's an Infectious Disease Society of America guidelines which defines this stewardship, that it's an activity for selection of appropriate antimicrobials, उनकी dosing proper हो, उनका duration antimicrobials proper हो, उनका appropriate route हो, and by doing all this, we can control the emergence of resistance, and ultimately we can reduce the treatment costs as well. Ideally, this is ideal composition of a stewardship team. There is a physician, pharmacist, microbiologist. The others may include epidemiologist, IT person, infection control. लेकिन जो minimum idea से बोलते हैं वो ये बोलता है कि physician and a pharmacist should be the minimum composition of any antibiotic stewardship team of any facility. So there are different roles of different healthcare workers in the stewardship. So physician का role यहाँ पर क्या है? The physician का role यहाँ पर ये बनता है कि अगर if the physician wants to start any antimicrobials on their patient, then they should ask themselves, does this patient require an antibiotic or not? Because there are different there's a difference between colonization and infection. ठीक है, वो colonization अगर मेरे यूरिन में कोई बग मुस्तकिल ग्रो किया जा रहा है तो वो मेरी colonization है, unless or until वो बग मुझे hurt नहीं कर रहा, unless or until मुझे sign and symptoms feel नहीं हो रहे UTI के. तो हमारे पास एक मिसकॉन्सेप्शन ये है कि कल्चर में जो भी ग्रो हो हमने उसको ट्रीट जरूर करना है. So we have to see we have to know the difference between the colonization and the infection. ठीक है, अगर मेरे पेशेंट, अगर फिजिशियन ये समझता है कि मेरे पेशेंट को इन्फेक्शन है और उसको एंटीबायोटिक की जरूरत है, तो वो उसकी एटलीस्ट इंडिकेशन मेंशन करे थे, why my patient required the antimicrobials. Have I ordered proper cultures before starting the antibiotics, and what empiric therapy should I initiate? So I've mentioned that empiric therapy. What does empiric therapy means? Empiric therapy means that that physician has to start the antibiotic by anticipating the bugs of the infection which is anticipating, by considering the facility antibiograph in their minds. कि मेरी फैसिलिटी का एंटीबायोग्राम क्या कह रहा है कि कौन सा बग किस एंटीबायोटिक के खिलाफ रेजिस्टेंट है और कौन सा बग किस एंटीबायोटिक के अगेंस्ट सेंसिटिव है. तो ये एम्पेरिक थेरेपी प्लेज अ वेरी मेजर रोल इन द सिलेक्शन ऑफ एंटीमाइक्रोबियल्स. अगर मुझे अपनी कम्युनिटी और अपनी फैसिलिटी का एंटीबायोग्राम के बारे में नहीं पता तो मैं वो एंटीबायोटिक एम्पेरिक थेरेपी सही से स्टार्ट ही नहीं कर पाऊंगा. चले मैंने empiric therapy start करके now I have to decide after 3 or 4 days or 2 days now what I have to do. Can I stop the antibiotic? Can I de-escalate to narrow one antibiotic, or can I change from IV to PO antibiotic? And last but not the least, that what duration I need, what duration should be sufficient for this patient. This is the major role of physician. There are certain physician barriers. There will be definitely अगर physician lead है किसी भी antibiotic stewardship का. Hello, आप लोगों को आवाज आ रही मेरी?
Yes, Kashif, continue.
Yes, Kashif, we can hear you.
Okay, fine. Okay, fine. So physician barriers. Physician is accountable, and you know, the chances of improvement are always here. Physician accountability यहाँ पर है. यहाँ पर physician ये सोच सकता है यार मैं stewardship कर रहा हूँ कि मुझे किसी को incentives मिलेंगे extra, ठीक है? Then what the physician thinks that what is the appropriate use of antimicrobial agents? यार appropriate use antimicrobials का होता क्या है यहाँ पर? So it might be कि हमारे पास कोई standard guidelines ना बनी हुई हो, ठीक है? इसकी वजह ये भी हो सकती है कि हमारा behaviorally ऐसा है कि हम कोई change accept करने के लिए तैयार ही नहीं है. और हमारा एक misconception ये है कि जी if ID consultant approves the use of any antibiotic, वो appropriate ही होगी, ठीक है? So mostly it is appropriate, but sometimes it might be wrong. So we have the right, physician have the right to ask the ID physician कि जो आप suggestion लिखकर गए हैं, what is the rationale behind it? ठीक है ना? What is the rationale behind it? क्योंकि हम लोग ID consult जब generate करते हैं, ID consultant आके अपने comments, अपने suggestion लेके जाता है. With due respect, हमें उनको respect देते हैं. लेकिन अगर primary physician अगर सोच रहा है कि नहीं यार ये antibiotic जो है मकसद उस पर मनो तन अमल नहीं करना चाहिए, ठीक है? The physician have the right to ask the ID कि ये आप antibiotic change लिख कर गए, इसके पीछे rationale क्या है? In the role of pharmacist in antibiotic stewardship, the pharmacist का role ये होता है कि जी वो हर antibiotic को देखे कि उसका indication mention है या नहीं है. Indication physician के लिए भी important है. Whenever physician is prescribing antimicrobials, then he or she should write the indication. Then the pharmacist should make sure that antibiotic orders are entered correctly based on the infection side. उस हॉस्पिटल का रेजिस्टेंस पैटर्न क्या है, हमारे रिस्ट्रिक्शन क्राइटेरिया उसमें फुलफिल हो रहा है या नहीं हो रहा. Do we need to optimize the dose of antibiotics based on organ dysfunction? Do we need to optimize the antibiotics based on their therapeutic drug monitoring, based on their site of infection? Because there are certain antibiotics जिनका certain site of infections में कोई penetration ही नहीं होता, ठीक है? For example, अगर मैं बात करूं, one of the example when I was doing the ICU rounds, कि हम E. coli ग्रो किया था एसाइटिक फ्लूइड के अंदर, ठीक है? अब E. coli एसाइटिक फ्लूइड के अंदर ग्रो किया है which was sensitive to aminoglycosides, carbapenems and extended spectrum penicillin. The physician selected to start the amikacin on the patient, ठीक है? When I was doing the round, then I checked यार ये E. coli ग्रो कहाँ कर रहा है? E. coli एसाइटिक फ्लूइड में ग्रो कर रहा है तो उसकी वहां पर पेनिट्रेशन होगी भी या नहीं होगी? तो उसका जो एसिडिक पीएच होगा वो तो अमाइनो ड्रग्स को इनएक्टिवेट कर देगा, तो वो तो ड्रग वहां पे पहुंच ही नहीं पाएगी. मतलब this is just a common example कि we should also consider कि वो एंटीबायोटिक का उस साइट ऑफ इन्फेक्शन में पेनिट्रेशन है या नहीं है. Then follow up the microbiology cultures के एंटीबायोटिक का जो हमने कल्चर भिजवाए थे उसका रिजल्ट क्या आया, हमने de-escalate एंटीबायोटिक करना है या नहीं. These are the roles of physician as well as the pharmacist. Then recommend intravenous to oral antibiotic conversions, monitor and preventing the antibiotic associated drug related adverse events, and then assessment and development in the use of antibiotic use policies. Antibiotic stewardship policies बनाने में pharmacist role play कर सकता है. अपना जो restriction policy के अंदर pharmacist role play कर सकता है. And issues addressed to be need by the pharmacist. The pharmacist at least should not dispense antibiotics, antimicrobials without a prescription. Repeat prescriptions per antimicrobials pharmacist dispense na kare. Pharmacies can be used as a campaigns in campaigns to promote and conduct awareness on the use of antimicrobials. Pharmacists can give education to the patient on antimicrobials, antimicrobial resistance related issues. Pharmacist rules को train कर सकता है pharmacist. Prescribing physician से cooperate कर सकता है. Antibiotic stewardship को एंटीबायोटिक स्टूवर्डशिप प्रोग्राम के अंदर जो है एक मेजर रोल प्ले कर सकता है. इसी तरह नर्सेस का रोल भी काफी इंपॉर्टेंट है इस एंटीबायोटिक स्टूवर्डशिप के अंदर कि ट्रायल्स के ऊपर नर्सेस कैन आस्क द पेशेंट रिगार्डिंग एंटीबायोटिक एलर्जी के आप लोगों ने लास्ट एंटीबायोटिक कब लिया, उसका ड्यूरेशन कितना था, कितना कोर्स आपने मुकम्मल किया, किस डॉक्टर ने आपको प्रिस्क्राइब किया था एंटीबायोटिक्स. और फिर इसके बाद जो है नर्सेज जो ड्यूरिंग द राउंड फिजिशियन के साथ इंटरेस्ट रह सकती है कि डॉक्टर साहब यू हैव स्टार्टेड दिस एंटीबायोटिक, इस एंटीबायोटिक का इट्स ओके टाइम आउट, कट ऑफ टाइम. फॉर एग्जांपल 72 आवर्स के बाद आपने एंटीमाइक्रोबियल्स का यूज रिव्यू करना है तो नर्सेज कैन रिमाइंड द फिजिशियंस आफ्टर 72 आवर्स दिस एंटीबायोटिक वाज स्टार्टेड 72 आवर्स बिफोर, नाउ व्हाट आर योर प्लान्स, whether you want to continue the antibiotic or you want to de-escalate the antibiotic or you want to stop the antibiotics. So there are mostly two antimicrobial stewardship strategies. These are known as core strategies. One is prospective audit with intervention and feedback, and the second one is formulary instruction and pre-authorization. Formulary instruction, जो है, if we allow formulary instruction, then it can lead to significant and immediate reduction in the antimicrobial use and cost. Lekin there are certain advantages and disadvantages of formulary instruction. That although it is the most direct control of controlling the antibiotic usage, but इससे ये होता है कि physician जो prescriber होता है वो he or she thinks that I have lost my power. I have lost my power of prescribing the antimicrobials. ठीक है. Education, creation of guidelines, and through certain antimicrobial stewardship committees or antibiotic subcommittees, review and feedback mechanism is very important one. We review daily our antibiotics for their appropriateness and then contact prescribers with the recommendation for alternative therapy. Then the last is computer assistance and information technology. Through information technology, we can make some softwares which will help us in maintaining the data of a stewardship program. Why imperative? Why antibiotic stewardship is important? As I told before, to overcome the antibiotic resistance as well as to avoid the adverse reactions which are caused by antimicrobials. So there are mostly 5 Ds of stewardship. The diagnosis, if the diagnosis is right, then we will be able to select the correct drug. If we are able to select the correct drug, then the dose should be correct, the duration should be correct, and then the de-escalation on the proper time. In sepsis, antibiotics, the sooner is better. So there is most of the literature इस पेपर है कि जी हम सेप्सिस के अंदर जितनी जल्दी एंटीमाइक्रोबियल्स एंटीबायोटिक्स स्टार्ट करेंगे उतना ही जल्दी जो है हमारा इम्प्रूवमेंट होता है. ठीक है. सो इट जस्ट शोज अ ग्राफ कि विद द पैसेज ऑफ टाइम द मोर्टेलिटी इंक्रीजेस. सो विदिन 1 to 2 hours the mortality is about 5 to 10 hours, and then with the passage of time the mortality increases. So first whenever we start a new program or we are going to implement a new program, so we have to do a pilot project first in one area, then second area, and then we have to implement in the whole facility. So we do our first pilot in the PICU, pediatric ICU, under Dr. Anmarul Haq. और मुझे याद है कि मैंने आई डिड दिस प्रोजेक्ट अलॉन्ग विद डॉक्टर अनवर था. उस वक्त डॉक्टर कलब शायद फेलो थे वहाँ पर उस वक्त जो है, एंड वी डेवलप द फॉर्म फॉर एंटीबायोटिक स्टूवर्डशिप के जो है जस्ट कॉमन क्वेश्चंस वर देयर इन द फॉर्म के पेशेंट किन एंटीबायोटिक्स पर है, फॉर हाउ लॉन्ग द पेशेंट इज टेकिंग दिस एंटीबायोटिक्स, for how long the patient is taking antibiotic, indication क्या है antibiotic की, उसके कल्चर्स भिजवाए गए हैं या नहीं भिजवाए गए हैं, एंटीबायोटिक कब स्टॉप हुई, फार्मासिस्ट का उसमें इनपुट क्या था, कल्चर्स में क्या आया, आईडी कंसल्टिंग, मकसद दिस वाज जस्ट अ सिंपलेस्ट फॉर्म, फार्मासिस्ट उस फॉर्म को फिल करता था, and then we did a project of over 4 months, and then we got the very good results, and I will show the results later on. Then we do the second project in the surgical ICU, adult ICU, along with Dr. Faisal Khan के साथ हमने ये project किया था, और it was also very successful project, and then we started it in our hospital. So this is our PICU based जो हमने किया था, PICU के अंदर एक antibiotic stewardship का किया था. As we can see that ASP minus the first graph shows that the patients who are on more than 5 doses of antibiotic were 64. जब हमने stewardship शुरू किया तो it got reversed. Less than 2 days का मकसद हमारा वहाँ पे कट ऑफ टाइम हमने रखा था अपना 48 days अपना कट ऑफ टाइम हमने रखा था. You can see here कि patient days of therapy हमारे कम हो गए, days of therapy हमारे ceftriaxone के कम हो गए, 532 से 186 हो गए, vancomycin हमारा डॉट कम हो गया, meropenem हमारा डॉट कम हो गया. So you can say तो हमारा around 60% reduction antimicrobials का कम हो गया था उन 4 महीनों में जब हमने ये प्रोजेक्ट अपना पायलट प्रोजेक्ट किया था. And then we do our stewardship project, pilot project in surgical ICU. यहाँ पे हमने जो अपने एंटीबायोटिक के मेन डेज ऑफ ड्यूरेशन डाले कि जहाँ हमारे ड्यूरेशन ऑफ एंटीबायोटिक जो है वो कम हो गए. Then we did the defined daily dose, जहाँ पे हमारी defined daily doses जो हैं वो एंटीबायोटिक से कम हो गई. I told you in the early stage कि जो हमारे antibiotic stewardship हमारी कमेटी बनी 2017 के अंदर, उसकी strategies यही थी कि reduce the resistance, advisory and education role होगा हमारी कमेटी का, and the leadership commitments. So these are the core elements of ASP which are defined by CDC as well. The leadership commitment is very important. अगर हमारी leadership commitment होगी, then this program will get success. Leadership commitment, accountability should be there. Drug expertise, as I told, if the physician is ID trained, if the pharmacist is ID trained, then the program will be run nicely. What will be the actions taken by the committee? Tracking हम किस तरह करेंगे, reporting किस तरह करेंगे, और अपने staff को educate किस तरह करेंगे. This was the memo which was circulated through all over the hospital by the CEO of our hospital, that we are going to start the stewardship program in our hospital in 2017 के अंदर. So we also adopt the core strategies of the antibiotic stewardship layer, like formulary restriction, prior authorization. We include those like linezolid, fosfomycin, tiki, caspofungin, all others. All drugs are entertained by the pharmacy whenever there is a ID approval. And then the second mechanism was prospective audit with feedback mechanism. इसके अंदर हमारे साथ क्या होता है कि we have defined some strategies कि for example कोई patient bacterial meningitis का है, अगर उसको कोई antibiotics inappropriate चल रही हैं, उसके cultures नहीं गए, 72 hours से ज़्यादा therapy हो गई है, severe sepsis, septic shock, appropriate, inappropriate का मतलब होगा कि 72 hours हो गए therapy को, negative cultures हैं, radiological examinations are not suggested for infection and not recommended by ID. If ID on board, it will be appropriate. If the patient is of sepsis, septic shock, neutropenia, pneumonia, it is appropriate. If the patient is of bacterial meningitis, it is appropriate. So the stewardship which we are running in our facility is basically a pharmacist-led antibiotic stewardship. We review the patient profiles on daily basis for those patients who are on more than 3 days of antimicrobials. But we target the antimicrobials. We target most commonly ceftriaxone, carbapenem plus vancomycin and colistin. So if we find that some antimicrobial is inappropriate, and we put this stamp in the patient file note. Appropriate or possibly inappropriate. If possibly inappropriate, please either take an ID consult for further continuation of therapy or stop or change the regimen. Please comply within 24 hours. फिर इसका फीडबैक मैकेनिज्म हमारा ये होता है कि after 24 hours we check whether our interventions are accepted or not. Then we do email the consultant, and then by keeping in mail CC the chair of the Antimicrobial Stewardship Subcommittee and the head of the department of that physician कि जी आपने हमारी इंटरवेंशन को एक्सेप्ट कर लिया, वी आर हैप्पी कि आपने एंटीबायोटिक डीसी कर दी, या वी आर हैप्पी दैट आपने आईटी को ऑन बोर्ड ले लिया. If they do not accept our intervention, then we mark them non-compliant. तो फर्स्ट ऑफ ऑल हमने अपने अस्पताल का डेटा निकाला, तो हमारे पास हमारे हॉस्पिटल में जो है दिस वाज 3 most common antimicrobials used in our hospital. Number 1 is ceftriaxone, second number पे carbapenem with peptide था, and third number पे जो vancomycin and along with amoxicillin. So we have to create happy environment, healthy antimicrobial prescribing initiative. So it has 4 branches. It should have some committee. We should have some antimicrobial guidelines, should have some standards. Pharmacist round, and we have done some little bit CPOE modifications, computerized physician auto entry के अंदर हमने कुछ modifications किए. हमने यहाँ पे modification किया कि whenever the physician enters the order antimicrobial, so it gives the 2 options, perioperative antibiotics and empirical or therapeutic antibiotic. If the physician selects the perioperative antibiotic, it has the maximum duration is 2 days. If the doctor selects empiric or therapeutic antibiotic, the physician can select the maximum 7 days for the duration of antibiotics. After 7 days, the physician has to review the use of antibiotics by any means. Then we put some alerts in the system for the restricted antibiotics, that this antibiotic is restricted. Have you got the approval from ID of a physician or ID pharmacist? So this is our just data. We got 100% approvals in case of formulary restriction. Those antimicrobials which are included in formulary restriction policy. You can see that in Q4 2020, their approvals are more than any other year. The reason is that we include remdesivir and tocilizumab in our restriction policy due to COVID-19. Remdesivir was using inappropriately initially, but when we realized that it has been used inappropriately by the physician, then we do include this remdesivir in our restriction policy. This is the compliance of our prospective audits which we did. The compliance, in between 70 and 75. So if we say कि Q1 2020 में हमारी compliance 68% थी, Q2 में हमारी compliance 70 थी, Q3 में 78 थी, Q4 में 72% थी हमारी, ठीक है. As I told you that non-compliance means हमारा क्या है? The patient regimen was screened as possibly inappropriate and asked to discontinue the regimen or consult ID, but none of the actions taken. And on the left side graph, there are a number of ASP interventions, the interventions which ASP has done. There are the supplemental interventions, which are normally mostly pharmacy-driven. IV switch to PO include those antibiotics in IV switch to PO which have absorption of more than oral absorption of more than 85%, which includes ciprofloxacin, clinda, voriconazole, levofloxacin, and other drugs. And the second one is dose adjustment and optimization. In this case, also our pharmacist on the daily basis run the search report of those antimicrobials, and then they do ask the physician to change it to PO. And over compliance in this case is in between 85 to 90%. Whereas in dose adjustment and optimization, we have the compliance of almost 100%. And whatever we prescribe, whatever we say to the physicians, they do accept it. These are the DDD of antimicrobials, defined daily dose. It is done only in the adult patients. DDD is not done in the pediatric patients. Okay? Pediatric patients we can do the days of therapy. This is the DDD means the average adult daily dose received by an adult for a particular infection. For example, ceftriaxone has a normal dose of 2 grams per day. So इसकी DDD WHO ने define करी हुई 2 per day. तो जितना भी ceftriaxone हॉस्पिटल के अंदर इस्तेमाल होता है, उसका जो हम ग्रामेज कैलकुलेट करते हैं, उस टोटल क्वांटिटी को हम 2 से डिवाइड करते हैं. Then this DDD divide by the patient days and multiply by 1000. In this way, we can get the DDD per 1000 patient days. For example, initially अगर हम बात करें 2017 में हमारा initial data था जब ceftriaxone का DDD अराउंड 210 था. 210 का मतलब ये कि 21% of the patients received ceftriaxone per 1000 patient days. ठीक है, अगर हम अपना voriconazole के ऊपर आए तो we can see easily the voriconazole का जो हमारा कंजम्पशन है वो कोविड के अंदर बढ़ गया है. 57 का मतलब है अराउंड 6% of the admitted patients received voriconazole. हम एजिथ्रोमाइसिन का देखें, एजिथ्रोमाइसिन का जो है हमारा Q1 Q2 में जो है हमारे पास समला टाइफी का एक आउटब्रेक हुआ, तो उस वजह से हमारे पास बड़ा एजिथ्रोमाइसिन का यूसेज जो है, और अब जो है हर कोई कोविड के अंदर एजिथ्रोमाइसिन इस्तेमाल कर रहा होता है. तो Q4 के अंदर भी हमारा एजिथ्रोमाइसिन कंजम्पशन एज कम्पेयर टू Q3 वो थोड़ा सा बढ़ गया है. लेकिन गुड थिंग इज कि हमारा कॉलिस्टिन का यूसेज जो है वो एक स्टैटिक यूसेज है, क्योंकि हमने इसको भी रिस्ट्रिक्शन में डाला हुआ है कि आफ्टर 72 आवर्स कॉलिस्टिन के लिए भी आईडी अप्रूवल चाहिए होता है हमें जो है. तो आउटकम मेजर्स हमारे यूज सकते हैं कि वी कैन कंपेयर आवर एंटीबायोग्राम्स ऑन 6 मंथली और ईयरली बेसिस. सेकंड फॉर्म इन्फेक्शन कंट्रोल हो सकता है कि हमारे इस एंटीबायोटिक स्टीवर्डशिप से जो है वो इन्फेक्शन लाइक एमडीआर इन्फेक्शन रेट वो कम हुए ही नहीं हो. लेकिन एक एंटीबायोटिक स्टीवर्डशिप सिर्फ प्रोस्पेक्टिव ऑडिट करने से इसे कुछ नहीं हो सकता. दिस इज अ कंबाइंड एफर्ट. अगर हम अपने इन्फेक्शन कंट्रोल के मेजर्स को कंट्रोल करेंगे and everybody has to play their role, then we would be able to achieve our goal. So how can you help? How can we help? We can request the prescribers to document the antimicrobial indication on their charts. Are the antimicrobials warranted on the particular patient? And we should encourage the prescriber to request ID approval for restricted antimicrobials. We should question the duration of antimicrobials and encourage IV to PO switch. Yes, that's it, Dr. Naveed.
Thank you very much. I think so. That was an excellent presentation, Dr. Kashif. Before we will move on to the presentation, I would just summarize it and give the dice to Khalab Abbas to introduce the panelists, and then we will move on to the question and answers. So with the start of the presentation, Kashif has nicely described about the background why antibiotic stewardship is needed. It is mainly related to antibiotic resistance and adverse reactions, and solution to it is antibiotic stewardship program. And the team comprises of physician, pharmacist, ID, micro epidemiologist, and infection control team. He then described very nicely about the role of physician, physical barriers to it, role of pharmacist, which is quite very important, as well as role of nurses. And then he went in, he described the core strategies for antibiotic stewardship program, that is prospective audit with intervention and feedback, and formulary restriction with pre-authorization. He nicely described it with 5 Ds for antibiotic stewardship, that is diagnosis, proper drug usage, the amount of dosage, duration, and de-escalation. Followed by he discussed how we have started it, and we started it with the PICU with the antibiotic stewardship program with 64% reduction in antibiotic usage. And along with that, the core element of antibiotic stewardship, it should come from the leadership, and then it should be moved forward. After that, he discussed about different strategies and how of intervention, how the antibiotic stewardship should be progressed, and how by different interventions and one can achieve the control of antibiotics. One can achieve on the control on the antibiotics. So, Kashif, that was really nice and very fantastic presentation. I would give the dice to Palab Abbas. He can introduce our panelists, and then we can move on to question and answer session.
Thank you, Dr. Naveed. So thank you, Kashif, for an enriching presentation on antibiotic stewardship. So we will open the forum for questions and answers, and I am glad to introduce our panelists. We are very fortunate and honored to have with us Professor Sajid Maqbool. He is one of the legends and teachers of teachers in pediatrics with decades of experience. He is the first dean of Children's Hospital Lahore, and he has been very active in promoting pediatric subspecialties in Pakistan. And he is currently the editor-in-chief for the Pakistan Pediatric Journal. Along with this, we are honored to have Dr. Ikramul Haq, who is a diplomat, American Board of Pediatrics and Pediatric Critical Care Medicine. He is currently working at Sidra Hospital at Qatar as a senior pediatric critical care physician, and he is also an active member of antibiotic stewardship program at his hospital. We have Dr. Hanif Kamal. Dr. Hanif is a graduate of Dow University, and he is also a fellow American Academy of Pediatrics and American Pediatric Infectious Diseases. He has worked in the US as well as in the Saudi Arabia and has a vast experience in his field. Currently, he is working as a consultant pediatrician and pediatric infectious disease consultant and assistant professor at Liaquat National Hospital, Karachi. We have Yasmin Hashvani with us. Yasmin is a bachelor in nursing, and she has been involved in critical care nursing for last 2 decades. And currently she is working at the Ahan University Hospital as a nurse specialist in pediatric critical care, and leads the pediatric critical care at from nursing perspective at the AKU. And we have Dr. Raziella. Dr. Raziella is a pharmacy graduate, and he is currently working as assistant manager of pharmacy services at the Indus Health Network. Previously, he has also experience of working as a critical care clinical pharmacist, primarily working in the PICU and the Indus Hospital, and he has been also an active member of the antibiotic stewardship program. So this forum is open now for question, answer, comment, and discussion. And we would encourage our panelists, if they have something to comment, or we can start with the question and generate discussion from there. Dr. Naveed.
I think so. We can ask our panelists to share their views about the antibiotic stewardship. I can ask Dr. Sajid if he can share, followed by Dr. Ikramul Haq. Dr. Sajid, if you can share your views about the antibiotic stewardship program, its need in our setup, as well as how if you have any comments about the presentation about which Kashif has presented.
We can't hear you.
Sorry, is my voice is audible?
Yes, Dr. Naveed. I think we are unable to hear Dr. Sajid.
Yes, Naveed, I can hear you.
Okay, I can
So,
hear you now.
all right,
Yeah.
Dr. Sajid, if you can have your views about the antibiotic stewardship and the need for it in Pakistan, and uh, any comments about the presentation for Kashif?
Okay, first of all, can you hear me?
Yes, we can hear you.
Okay, thank you. First of all, thank you very much for giving me the opportunity. I have worked in pediatrics for a while, and am not only aware of the increase in the use of antibiotics, but also the problems that it has caused. The the matter of abuse or overuse of antibiotics, or the unnecessary use of antibiotics, was mentioned right at the outset. And this is very important for pediatrics, at least. It is estimated that whether it be a country like the United States or UK or Europe, or indeed the developing world, some of the commonest infections in pediatrics are treated wrongfully, especially when it comes to the use of antibiotics. Consider that the two commonest infections of children in Pakistan are respiratory and the gastrointestinal. So respiratory infections, majority of them are upper respiratory, and most of them are viral, yet we use antibiotics. And there are, of course, studies showing this repeatedly. Not only do we use antibiotics unnecessarily, but we use quite a few of them, sometimes in combination unnecessarily. And the same holds true for diarrheal diseases, which is also, again, viral, and we're treating it. So in some studies, we'll see that perhaps up to 60%, or maybe even between 60 to 80% of the time, we're using antibiotics unnecessarily. So that point needs to be emphasized. And we also, it was pointed out that we tell our colleagues to treat the patient and not the laboratory, not the lab results necessarily, if clinically this discrepancy between the microbiology, or for that matter, even hematology, and the condition of the patient. So we have to use our clinical judgment. So a good physician or a good pediatrician does that routinely. The matter of presence of an organism versus disease is something that comes up frequently. And now with COVID, we're seeing this also. The presence of an infection does not mean severe disease. And therefore, we have to differentiate between these. I'd also like to point out the use of what we call empiric therapy. It is based on the most likely organism, as has been pointed out, and in a particular hospital setting, what the previous experience with that particular infection and with a particular antibiotic has been, and that is how we treat it. So if you look at the tonsils, for example, and if you think the age is appropriate, a school-going age, and it meets the criteria, yes, you can use an antibiotic. But in again, we often see children, actually some of age, where the emergency room and some good hospitals, the diagnosis is, whereas we know in that particular age group. And of course, then is the I'm glad that it was mentioned that when you have 2 or 3 antibiotics listed in the possible effectivity issue, you have to decide on the age. You have to look at the age of the child. You have to look at the function of the various organs, for example, the kidneys, the liver, how is that excreted? and how is it metabolized? Where is the level appropriate? So some antibiotics, for example, will cross the blood-brain barrier when there is inflammation, and the same will not when the meninges are not inflamed. And of course, there are other examples. So the antibiotics, as far as I'm concerned, need to be selected very, very carefully. Also, I would say one other thing, and that is, you did mention the route of giving antibiotics intravenously, intramuscularly, for example, mostly intravenously in the PICU setting, etc. Yes, sometimes we have to do that. But when you're talking about antibiotics in general, you have to understand that the best way, if we can, is to administer most antibiotics by mouth, which is the safest way, and sometimes just as effective, unless the patient is in a situation where these need to be given in very high doses very quickly, and you need high peak levels or high levels right away. For the average patient, you have to keep that in mind. So you have to be very specific when you use an antibiotic. You have to know the route of administration, the dosage, the duration, as has been pointed out very, very nicely. Just one other word. The focus here was in the hospital in a tertiary care setting. We in pediatrics feel that this applies just as well to the outpatient setting and to the practice setting, etc. And we have to be just as careful about what I call the abuse of antibiotics. And lastly, reference was made to the fact that antibiotics or antimicrobials in general, if I want to include antivirals and antifungals, are not really simple, straightforward drugs. They have very serious side effects. We have seen anaphylaxis. We have seen, very, very serious conditions. We have seen necrotizing enterocolitis and so many others that pediatricians are very aware of. So it is with a great sense of responsibility that you need to use antibiotics. And as we have further discussion, I can also, if you'd like, mention the importance of immunization as a preventive tool in the use of antibiotics. So I think I've spoken quite a bit, so I'll stop here because you have other people to say a lot of other nice things. Thank you again.
Thank you very much, Dr. Sajid. I think so. These were excellently noted, and the things were to the point. Dr. Kram, do you want to comment anything on antibiotic stewardship?
Hi guys. Salam from Qatar to everyone. You guys are a few hours ahead of us, but it was a very nice presentation. Kashif did a great job in summarizing real quick, which is a very vast topic in my mind to do. So the science is something which is easy to understand. People know all of these things, right? I think you will hardly find anybody who will disagree with you when you say, the antibiotic resistance is going up, and the overuse of antibiotic is happening. The data and the science is easily understood, but when you start developing a program to control the situation, right, and to make things better, that is when it becomes hard. So I listened to Kashif's presentation because he presented some data as what you guys have done at Al Khan and other places, and so very encouraging to see that you guys were able to do some of that, and it looks like you guys are now tagging this along with the computerized physician ordering entry system and trying to utilize that. I have a few questions for Kashif. It is still available, just out of my curiosity, and maybe it will be of interest to the audience to do. So, to get the buy-in when you start the program, so you develop the committee, you develop the guidelines, right? What did you guys do to get a buy-in other than, I see like a system where there was like an email system that was going through, and I heard that maybe a chief of the division or the director of the place was notified in tandem. So it was like more like a, we call it a danda on the, like danda, right? So you do it, otherwise, there is an email coming to your boss, and your boss may be very upset after finding out. What were the things you guys did to educate people? Do you guys share antibiogram of your local regional area with your doctors? How do you get the buy-in from, of course, the people beyond the steward committee?
Yes, Dr. Gram.
As you said, can you unshare your screen?
Okay, sure.
Yeah, and then you can, yeah, now you can proceed, please.
Yes, Dr. Ram. As you said, danda. So danda, is very important in our culture. The time we don't put danda on our people can't do the work, really. Initially, we developed this antimicrobial guidelines in 2017, and we do, basically it was for the surgical side initially, as the antibiotics used in surgical ICU was very inappropriate. So we took the buy-in of all the surgery departments, whether it is general surgery, neurosurgery, vascular surgery, whatever surgery it is. We took their buy-in, and then we took did this pilot project over there in surgical ICU, and then we make the guidelines of all over the hospital. Right now, currently, we do face some difficulties in the compliance, especially if we talk about the cardiothoracic surgery. The most non-compliant department in our facility right now is cardiothoracic facility. We tried our best to convince them, but we are not trying to be really very strict or very harsh with them. We do contact our CEO regarding this, and we hope कि हमारी जो non-compliance है थोड़ी सी इन CTS के अंदर वो थोड़ी सी बेहतर हो जाए. इनफैक्ट हम लोग जो है टाइम टू टाइम डिपार्टमेंट्स के अंदर जाके जो है उनको एजुकेट करते रहते हैं. नाउ वी हैव डेवलप्ड आवर न्यू गाइडलाइंस इन एंड these are going to be published in a day or two. We have worked the whole year in 2020 to establish these guidelines by taking the buy-in of all the departments again. कि जी अब ये आप लोगों के buy-in से दोबारा guidelines बनाई गई हैं. Now please follow these guidelines. ठीक है sir.
So, Kashif, so a couple of more questions that just,
sure.
So you presented some of the process measures, right, with your project you have done. So the process measures are actually, you show that how much usage is, right? And then what has happened to the usage over time. And so the outcome measures, although you did alluded to them a little bit, referred to them, but were you able to measure any kind of outcome measures? Like, so the reason I was talking about is that, with our efforts here or the places where I've been before, the physicians do listen to, like, agar at the end of paisa dikhaएं लोगों को कि भाई ये आप बचते हैं, maybe उसका कोई incentive हो department की तरफ से, तो वो that makes more sense. I know that the data for antibiogram change, right? Unfortunately, कोई ऐसे studies इतने अभी नहीं हैं, or maybe I will say mixed results हैं where up antibiogram for resistance, जो आपका primary goal होता है कहते हैं यार मैं resistance, I have to change it, but there is no good data to show that yes, actually this stewardship can does that, right? Or have proven that. Theoretically extrapolate karke, we say that, but any kind of outcome measures you were able to like gather, which you can share with your team and say, look, this is how good we are doing. Sure, you are using less antibiotics, but the interest is what is the money at the end of the game.
Oh yes, it's very important. As you said, the antibiotics ka abhi tak maqsad, it takes time to improve the pattern of antibiotics. We have to we do show the cost savings in terms of pharmacy. For example, whatever we save from convergence of intravenous to oral convergence, and whatever we ask for our interventions to just stop this antibiotic, or for example, that the physician has entered the meropenem for 7 days, and we entered at the and we intervened after 72 hours. If the physician stops an antibiotic after 72 hours, then there are 4 more days. So fourth is a 12. So we save the 12 doses. We save the cost of 12 doses of carbapenem, or for example, meropenem, right? So in our facility, the around one dose, 1 day meropenem cost around 6,000 to 8,000 per day. So it is 6,000 per day, and we save the doses of 4 days, then it will be around 24,000. We save the patient, and we do show the cost saving in our committee's reports. We have saved this much amount. Although I have not shown in this presentation, but we do show in our presentations in our committee.
Yes. So my recommendation was that is actually very important data. And then when you are presenting, you should include it in your, because, you know, people, process measures are good. People look at process measures, but outcome measures are something which really have the impact at the end of the line. And then, Kashif, there is one more. I don't want to be taking all the time. I know there are other people who want to have questions. Very nice presentation. This is just one thing, and I don't know. Please don't take it in a different way. It's just the one way. So I just wanted to point out the data you presented for the, you know, the compliance data over the time, right? And you made pie diagrams for it to present.
Yep.
What I was going to suggest that, you know, you can use like something like what looks like control charts to show, like a line graph rather than a pie graph. So because, you know, visually when people are looking at something, what makes sense to us is looking at like how the compliance is going like this, or a line is coming down like this way, or the line is going up like this way. That is much better visual effect than you know, the percentages in the pie diagram. It makes it difficult to follow because what you're doing is a continuum of time, right? And over a continuum of time, you are showing that what change your compliance is having. So I'm talking about that slide where you have the 2 pie charts for different quarters, just as a you know, as a visual thing for the presentation.
It's fair enough, sir. Thank you, sir. Thank you.
Okay.
Fair enough.
Great. Good job. Thank you.
Sure.
I really was nice to hear this talk.
Okay. Thank you, sir.
I will not. Sorry. Is my voice is clear now?
Yes.
GG.
I would ask Dr. Hanif Kamal to share his views about the antibiotic stewardship, as he's the ID person, and it must be एक दुखती drug होगी इनकी. So I will ask him to share his views.
Thank you very much. It was a nice presentation indeed. And it's remarkable that we are having these sorts of stewardship program in Pakistan. It's very much needed, as pointed out. Antimicrobial resistance is a nightmare worldwide. And people in Pakistan, they are very lax about, even the doctors. यानी मैं residents को बताता हूँ यहाँ पे antibiotics कोई भी prescribe कर सकता है, मेरी वालदा भी करती है, मासी की बच्ची जब बीमार होती है. And people are doing that right and left. Even the doctors, they think they know how to use antibiotics, but antibiotic usage is an art. It has to be learned. No one is born with it. ये नहीं मतलब कि MBBS है तो he can use antibiotics right and left, whatever he wants to. Otherwise, we will, each and every one of us will bear the consequences. There are susceptibility patterns right now in our hospital. Klebsiella not sensitive to a single antimicrobial. Peritoneum से grow हो रहा है, blood से grow हो रहा है. And the other antibiotics you spoke about, ceftazidime, verobactam, another thing, avibactam, ceftazidime, meropenem, verobactam, and other things, we cannot speak about it. There is a child I'm treating, skull osteomyelitis, pseudomonas, resistant to every medication possible. Okay, so it's the having a antimicrobial stewardship program is a must. It's a standard of care. Quality जो management है, quality control जो है आजकल hospitals में, that's the most important thing. पैसा कितना बना रहे हैं, कितने मरीज देख रहे हैं, that's irrelevant. That's not for us. वो जो है वो तो जो administrator है, जो आपका ओनर है उसके लिए है, उसकी जेब में जा रहा है, हमें तो लगी बनी तनख्वाह मिल रही है, ठीक है. But if we care about humanity, if we care about our patients, then we have to work for this thing. And having a structured antimicrobial stewardship program, जो कि prospective हो, जो कि 24/7 हो, हर culture को follow करे, it has an impact. I have worked in places, Saudi Arabia and other places, वहाँ पे इम्पैक्ट होता है, सिर्फ कॉस्ट सेविंग का ही नहीं होता. ये जैसे डॉक्टर इकराम ने मेंशन किया, वी सी चेंजेस इन द ससेप्टेबिलिटी पैटर्न्स, और इट बिकम्स वेरी यूजफुल, और आपको जो सेटिस्फेक्शन मिलता है कि हाँ भाई यू आर कंट्रीब्यूटिंग टू समथिंग पॉजिटिव. So Aga Khan and the pharmacy department there has to be congratulated कि उन्होंने सेटअप किया है, but this information has to be disseminated. We are next door to Aga Khan, Liaqat, but it's a nightmare there. इसी तरह कराची के किसी हॉस्पिटल में चले जाए, people are writing tigecycline left and right. इस वक्त पूरे कराची में शॉर्टेज है, टाइगीसाइक्लिन मिल नहीं रही. क्यों नहीं मिल रही? कि अब उन्हें पता चल गया है कि पहले every patient who came stepped in the ER or PICU or ICU, meropenem, Venco, colistin. This is the holy combination right now. Every patient who is admitted is on these antibiotics. But if there is an active antimicrobial stewardship program, जहाँ पे restrictions होंगी, जहाँ पे monitoring होगी, तो वहाँ पे आपको लेना पड़ेगा. एक डोज या 2 डोजेस रिलीज हो जाएंगी, लेकिन उसके बाद नहीं होंगी. And but it has to be implemented, and this is a sensitive point in our culture. वहाँ पे लोग कहते हैं कि भाई हमारी उसको knowledge को, authority को question किया जा रहा है. I'm the physician in charge. This is my patient. Who has the authority to question me? ये सारी चीजें जब information disseminate होगी, people will know the benefit and they will see how effective it is and how useful it's going to be. It will be very, very beneficial for all of us. So congratulations. I'm really delighted to be a part of it. Inshallah, I think things like this will be everywhere in most of the hospitals, and inshallah, things will improve. Thank you very much.
Thank you very much, Dr. Hanif. I will ask Yasmin if she is there.
This is Ikram. Sorry, Naveed.
Yes,
Dr. Hanif said very important thing, and I've been out of Pakistan for a long period of time. So, but this was the case even before Dr. Hanif. I remember that you could just go to the pharmacy and tell him that you are having throat pain, and then the pharmacist right there will give you the antibiotics, right? I'm actually, still a little bit not much surprised. I think that happens, right? So that the people get, but one of the things for Kashif and other guys, what we worked, so we had a lot of deliberation of one other mechanism you can have. तो जो आप जैसे आप भेजते हो ना कि ईमेल भेजते हो, हमने क्या किया है eventually after a lot of discussion, right? And I can tell you that a lot of resistance, almost like World War III शुरू होने वाले हमारे hospital में between different लोग, भाई antibiotic को यूं कर रहे हो कर रहे. तो हमने क्या किया है eventually we approved कि हमने hard stop कर दिया है. तो वो एक चीज होती है जो computerized ordering entry system में, you can go into a hard stop. So what happens, it calculates, आपका clock run करता है 48 hours पे. अगर आपका ID का approval नहीं है उस पे, या कोई पॉजिटिव कल्चर नहीं है, तो वो जो इलेक्ट्रॉनिक मेडिकल रिकॉर्ड से वो एंटीबायोटिक डीसी हो जाता है, स्टॉप हो जाता है, और फिर मतलब अपनी मजीद डोजेज आता ही नहीं है फार्मेसी से कि यू कैन गिव इट. So it took, वही मैं काशिफ से पूछा था कि आप बाय इन कैसे कर रहे हो, तो सही बात है, थोड़ा सा डंडा भी करना पड़ता है. तो हमने one of the mechanism we used was this hard stop using the EMR system, and that has also improved our, because you just can't use it. That's it. The order will disappear. आप order नहीं कर सकते हो. And then जब भी आप order करने की कोशिश करोगे तो you will get this flash, and just like आपका system है ना कि it alerts you to talk to the ID person or the fellow. That's what will happen. तो I don't know आप लोगों ने ये सोचा है कि नहीं कि hard stop का mechanism. It's a tough deal because बहुत concern लोगों ने किया कि भाई antibiotic अचानक बंद हो जाएगा तो patients को नुकसान होगा, यूं होगा. But we did long study to look at it, what the situation was. Or अगर restricted number of antibiotics हो ना, तो it's much easier to implement. Sorry, I didn't mean to take time, but I just thought that I will mention this strategy also. A lot of deliberation, but it could be done.
Yeah.
So, Dr. Ikram, thank you for bringing this up. So, I would like to ask you a question that I just came across a study that was done, I think, in a single center somewhere in US. I don't remember exactly. And what they did is that they compared the antibiotic prescription habits of intensivist and an ID physician. And you know what, that ID physician were more liberal with prescription of antibiotic compared to intensivist, and intensivists were very conservative. So my question is that in the end, we are putting the whole burden to the ID physician, while intensivists who are working, if we talk about specifically about the PICU, who know in and out of the patient, the major problem, and while ID physician just walk in for maybe 1 hour, couple of hours and not more. So how do we balance these things? Sometimes we have to fight the other way, that they think that this antibiotic should be given because the kid is improving, and what happens is that we forget that there are certain other interventions being done with the patient, and it's the patient's physiology which is improving, and that might not necessarily be because of antibiotic and some other sport with the patient had. So how do you balance this thing, or what's your take on this?
I mean, excellent question. And I think, everybody who's in here probably knows this, right? So everybody's saying, yes, this is the problem. These are tough questions. The ICU get a lot of latitude, right? That because the patients are sick, right? And I can just tell you that some of the papers from US, right? So we look at it, but you have to know the environment there also, right? There is a term people use calling defensive medicine, right? Which is applied a lot there because oftentimes you are more worried about something is going to happen, and then the patient will complain, a lawsuit will happen, and then you would get into trouble. So because of that, like when you are placed in a position of, a responsibility, and then the intensivists turn to you, they have certainly an issue. And the problem is that we don't have good tools to be accurate about anything, right? So, one of the things, and I don't know if you guys do, we have used this strategy. I don't know if it is helpful in not using the antibiotics or so, which are like some other tools you use to decide, like, inflammatory markers. The one we use in Sidra here is procalcitonin. So what we do is we send procalcitonin every time you get like a inflammatory type problem, fever or something. We send procalcitonin, and so then if the procalcitonin is high, that reassures you. So at least what happens, people will be worried anyway. They will start antibiotic anyway. But stopping it, I think with these markers have gotten much easier. And Kasha was talking about cardiothoracic surgery. I can trust you that our surgeons, the cardiothoracic surgeons, so sometimes, it used to be a big problem before. The white cell count is not really that high. The patient has fever. And they will say, well, we cannot go to the OR now. That's it, because the patient has an infection possibly, and then we, treat it, right? So now what happens that our surgeon, after a lot of this stewardship and then this, have come to, they are becoming to ask this question, what is the procalcitonin? And if, if the CRP and procalcitonin is low, and then you can argue that the white cell count is low, and this is not that, and there are other reasons or what have you, they are more amenable to now, becoming a little bit more. So maybe, for you guys, we haven't done that job very well, but you guys coming in need to look into start doing that also, right? Looking at it so far, these strategies like with other biomarkers trying to kind of decide has not really worked very well, right? In some areas, maybe in neonatology, I think they use it very well to decide if they want to start or not. But in PICU, I don't think it's well established. But at least you can stop it. Stopping it, I've seen it more effective. And then, this problem, I think, will remain always. I don't think that you will get 100%. Dr. Hanif, you can, not make him 100% compliant with your thoughts always, right? So what we do in our hospital is that we, at the end of the day, for this antimicrobial, we have let the rest at the end of the line. The real expert is your ID specialist, and you have to just trust that. And then we just document. If they document, we document, and we say ID was confirmed, and antibiotics will stop. And then we just follow and hope that the things will be okay. That's what we follow. Right.
So, Dr. Hanif, any comments?
Yeah, no, I totally agree. I totally agree. I think there should be more communication, direct communication, instead of writing notes or EMRs or talking to the residents. If we educate the other team and tell them our thoughts, why are we thinking like this in detail, openly, and it becomes more clearer to them. And if there are any assumptions, their fears, wo address ho jaye, then it becomes more. Sometimes miscommunication hota hai, things we are not on the same page. Phir uspe then there are more differences. But I agree there should be more education and use of inflammatory markers. In Pakistan now also, we are using procalcitonin. It's available. Yep. It's a little bit expensive, but we are using it. And it should be used, especially in the gray zones. And I totally agree that there will be differences, but we can minimize them as much as possible with education and discussion.
One more thing I was going to tell you, कि हम जो है हमारा ID stewardship एक sort of like a subcommittee समझो इसको ID lead करता है, and then what we do in our unit is that twice a week, 2 दिन हम लोग दोपहर के around जब round खत्म हो जाता है उसके बाद we do a quick round where everybody meets, and now this Zoom MS Teams is pretty easy. Everybody comes, and then every patient in the unit who's on antibiotics, we discuss. And then at that time, like ICU team has to rationale why they are using something, and then the ID gives information, and then we make up plans also. So that has been very, very helpful. People are very happy with it. So we do it twice a week, at the beginning of the week and then before the weekend. And so then, the plan continues, and it takes about 10 minutes of a meeting. We have the ID specialist, the pharmacist, the infection control team person, and then the ICU team, and we just go over all the patients and say why these antibiotics are on. So that has been also helpful as a strategy.
Yeah, I think direct communication is one of the key there, because you get the thought process from each other. And do you have microbiology's input in such cases when deciding?
Yes. So we the infection control team has a microbiologist, and luckily we have that. In addition, in our ICU, the Denda walks around with us in the round, so we have actually a clinical pharmacist around with us.
Yeah, I think
they are right there, and then like why this is on, and adjust the dose, do this, and the LFTs are this today, or the creatinine is this we need to do. So we do have that advantage. But maybe I think that over a little bit of our participation of a clinical pharmacist, maybe an hour or two of their daytime work, and if the institution can support it, is worth it from this perspective of stewardness.
Yeah, so I still remember, as Kashif mentioned, that when we initiated our pilot program in the PICU, so Kashif, I was the point person for the PICU, and Kashif used to come and ask, Talab, why are you giving this antibiotic to this kid came with viral pneumonia, this came with community acquired pneumonia,
यार
why are
आप
you
लोग
giving
कराची में
meropenem,
हो
etc.
तो ये आता था पहले इसको चेक करते थे, कोई लेके नहीं आता असला शसला कोई ये काशिफ कराची के लोगों से तो कुछ पता नहीं, तब तो यही सुनते हैं।
इवन असला नहीं भी लेके आता था, बट वो हालात ऐसे होते थे सो
दो चार सारे इंटेंसिविस्ट जिंदा हैं प्रोजेक्ट के बाद।
but that ingrained these queries in my mind, and now I ask my team, okay, why are we giving this antibiotic and why not this antibiotic, and even the ID physician. So I think this is how you change the culture and you build habit to the whole team, that then everybody comes on the same page.
Great. Yes, you are talking about culture. This is what it is, right? Culture. Yep.
Yeah, I think this is a very important point as far as the developing world is concerned, and especially Pakistan, and that is that this concept is relatively new for Pakistan, and people in Pakistan, and I know Dr. Saab, being in Qatar, I think you have a different perspective, but it is true that it is a matter of the turf, as we call it. This is like a turf war. And so when you first suggest that other than a physician will be involved in decision making, if it is not the primary physician, even when you suggest an infectious disease specialist, sometimes initially there is hesitation. And then you add on top of that the pharmacist. But over a period of time, the important thing is that if you recognize that these are important team members, then and you work as a team, I think it works fairly well. And you also, like you suggested, the microbiologist. We have seen time and again that, for example, they will come up with a culture of, we've seen typhoid, for example, very often here, not a problem in Qatar, but certainly here. And if you discuss it, go down, and other than rounds, discuss it with the microbiologist and discuss the clinical picture with him, you see the some aspects of the, it works both ways. The pharmacist will tell you, your dosage is not correct, or, for example, these are the findings. The clinician can also discuss this with the microbiologist. It works both ways. This is the evidence. The clinical picture looks very much like typhoid, and we have started first-line therapy, and the patient is responding, in this case, a child. Therefore, you're saying that this is not sensitive to this particular antibiotic. It doesn't seem to go with the clinical sense. And I found that most microbiologists are very understanding, and they do understand that there are clinical situations where the lab and the clinical picture doesn't tally. Just like you've said, reverse in reverse, where you may start an antibiotic and the pharmacist says review after 48. In children, we often do that after 48 hours or 72 hours. Then the clinician may then also, in mutual discussion with the pharmacist and with the microbiologist, may want to make necessary changes. I think this point of every checking every 72 hours, I think it's a very valid point. And also, physicians will often start antibiotics, even with those markers initially, but will then forget the duration of the therapy that the child has been on, since I deal with children. So they may just continue with the therapy much longer than it is necessary. And you mentioned neonates. We have a very high index of suspicion for neonatal sepsis, for example, and we'll often start antibiotics on some very soft signs after the cultures and the parameters are done. But it is equally important that the team decides 48 to 72 hours later, in view of what you have, whether it is the procalcitonin or the interleukins, or even the C-reactive protein, even in neonates, even the total neutrophil count, etc. Then it is equally important that you discontinue antibiotics when you think there is no evidence of infection, that you started something empirically. So it works both ways, and it is the team approach. I think that we haven't mentioned about one other thing, one other aspect, and that is they just mentioned it in passing. I think the nurses can play a very, very important role in all of this also, and they are as essential a member of this particular team as the pharmacist and the physician and the ID person and the microbiologist. Thank you.
Yeah, thank you very much, Dr. Sajid. So I think you rightly pointed out a few very important points in this whole team building. And as you pointed out, that nursing have a very important and unique perspective in this thing. So I would request our nurse panelist here, Miss Yasmin. So Yasmin, what's your perspective on this antibiotic stewardship and antibiotic usage? And I think nurses are one of the pillars who get us communicate to all the team members. So over to you, Yasmin.
Thank you, Dr. Abbas and team, to inviting me. I'm audible?
Yes.
Hello?
Yes, you are audible.
Here, I agree that nurses are very important role, playing important role in all this thing, not only in this antibiotic stewardship and other thing and other management of the critical care areas. And definitely this is our also the area where nurses need to get empowered when they are doing round and when they are doing the round and they are involved in the management. And when there is a time of the antibiotic, high dose antibiotic or antibiotics that is started, should be counted and days should be counted. And मतलब कि वो लोग को बहुत empowerment की ज़रूरत है और they can involve in all the planning also. So which we can be मतलब हम इतनी antibiotic जो long term तक चलती है या high doses पे चलती, we can drop it down to the lowest one.
Yeah, so I agree that this nurse empowerment and considering an equal partner in patient care is very important. And this is the mindset and the culture which we need to change as we move forward. So and next, I'll request our other panelist, Mr. Raziella. So Raziella, what is your perspective and what do you think, what your experience has been regarding the antibiotic stewardship and communicating with ID physician as well as with the intensivist as well as with the microbiology, etc. And what points do you have to suggest?
अस्सलाम वालेकुम। सबसे पहले तो आप लोगों का बहुत शुक्रिया इनवाइट करने के लिए। आवाज आ रही है आप लोगों को?
जी, yes. Go ahead.
हेलो
जी, आपकी आवाज आ रही है।
Raziella, we can hear you.
आवाज आ रही है?
जी, आपकी आवाज आ रही है। Go ahead, please.
मुझे 2 मिनट में थोड़ा स्क्रीन भी शेयर कर दूं, कुछ चीज़ें जो मैं शेयर करना चाह रहा था। तो ऑलमोस्ट काफ़ी तकरीबन सारी चीज़ें शेयर की हैं, लेकिन आई वांट टू ऐड समथिंग।
Yes, sure, go ahead.
स्टीवर्डशिप के लिए सबसे पहले हमारा एक गोल क्लियर होना चाहिए कि अगर हम एज अ टीम काम कर रहे हैं तो एक गोल जो हमारा है कि हम एंटीबायोटिक की अनइंटेंडेड यूजेस है उनको कम करें, ताकि हमारे एंटीमाइक्रोबियल रेजिस्टेंस और एडीआर जो हमारे एंटीबायोटिक की वजह से आ रहे हैं तो वो कम हो। तो इस गोल के लिए हमें एक एज अ टीम काम करने की ज़रूरत है। हमेशा इस चीज़ में जो मेरी एक एक्सपीरियंस थी, हमारी जो टीम में ना ये चीज़ बहुत लैकिंग हो जाती है कि फिजिशियन फार्मेसी के साथ एग्री नहीं होता, फार्मासिस्ट फिजिशियन के साथ एग्री नहीं होता, आईडी कंसल्टेंट कहीं और सजेशन दे रहा था, तो वो जो गोल है हमारा वो कहीं और रह जाता है। तो जो हमारा गोल है, मेजर गोल की तरफ, जो मेरे ख्याल में, जो मेरा ऑब्जर्वेशन है कि जो हमारा गोल है उसकी तरफ हम हमेशा लैग कर जाते हैं, उस पर फोकस नहीं कर पाते। इसके अलावा कुछ चीज़ें थी जो काशिफ भाई ने तकरीबन क्लियर कर दी कि रोल ऑफ फार्मासिस्ट क्या होना चाहिए, और को रिस्पॉन्सिबिलिटी क्या होनी चाहिए फार्मासिस्ट की, डीएस्केलेशन की तरफ, या स्ट्रीमलाइनिंग थेरापी हो गया, या डोज ऑप्टिमाइजेशन हो गया, डोज एडजस्टमेंट हो गया, प्योर टू ओरल कन्वर्जन हो गया, ये सारी चीज़ें उन्होंने क्लियर कर दी। इसके अलावा उन्होंने स्ट्रेटजी भी बयान कर दी कि एक बैक एंड स्ट्रेटजी है, फ्रंट एंड स्ट्रेटजी है। या तो आप प्री लगा देते हैं, फार्मूला रिस्ट्रिक्शन लगाते हैं, या आप प्रोस्पेक्टिव ऑडिट या इंटरवेंशन फीडबैक वाला मैकेनिज्म लागू करते हैं अपने इंस्टीट्यूट में, ताकि इनिशियल में जो एंटीबायोटिक की एडमिनिस्ट्रेशन है वो डिले ना हो जाए। तो ये 2 स्ट्रेटजी है जो ऑलरेडी काशिफ ने डिटेल में एक्सप्लेन की है। जो चीज़ मैं ऐड करना चाह रहा था वो था मॉनिटरिंग ऑफ एंटीबायोटिक थेरेपी। जो भी एंटीबायोटिक की थेरेपी स्टार्ट हो जाती है उसकी मॉनिटरिंग किस तरह की जाए, ये एक फार्मासिस्ट के लिए अगर कोई फार्मासिस्ट सेशन को ले रहा है तो उनके लिए बहुत इंपॉर्टेंट है। बीइंग अ फार्मासिस्ट उनकी रिस्पॉन्सिबिलिटी बन जाती है एज एएसपी टीम कि वो कुछ चीज़ें हैं जो उसको कॉन्स्टेंटली मॉनिटर करे, लाइक वाइटल्स हो गए, और लैब पैरामीटर में डब्ल्यूबीसी या टीएलसी ट्रेंड हो गया, सीआरपी हो गया, प्रोकैल्सिटिनिन हो गया, ये चीज़ें हैं जो उनको बहुत ज़्यादा ज़रूरी है। और एक नेक्स्ट स्लाइड है जो मैं शेयर करना चाह रहा था, जो जिससे अभी खासी डिस्कशन भी हो गई रिगार्डिंग प्रोकैल्सिटिनिन। ये है प्रोकैल्सिटिनिन की यूजेस अगर आप एंटीबायोटिक की मॉनिटरिंग के लिए प्रोकैल कराते हैं, क्योंकि प्रोकैल इज आपको रैपिड टेस्टिंग की फैसिलिटी भी देता है। अगर कॉस्टली है लेकिन दूसरी तरफ से आपको एज अ रैपिड रिजल्ट भी देता है, ताकि आपको एंटीबायोटिक के लिए जो भी डिसीजन ले रहे हैं वो आप ऑन स्पॉट ले सके। तो ये क्राइटेरिया है। अगर आप साइन एंड सिम्टम्स पे एंटीबायोटिक स्टार्ट कर देते हैं, डे 3 पे अगर आप प्रोकैल कराते हैं तो प्रोकैल के लिए क्या स्ट्रेटेजी होनी चाहिए। अगर आपके पास डायग्नोसिस कंफर्म है, माइक्रोबायोलॉजिकल कल्चर ग्रो हो गया, तो आप तो जो अप्रोप्रिएट एंटीबायोटिक है आइदर एस्केलेशन या डीएस्केलेशन की तरफ जाते हैं। अगर आपके पास फिर भी कोई कल्चर नहीं आता तो आप प्रोकैल कराते हैं 0.25 mg पर लीटर से अगर आपका कम है तो आपके लिए वो स्ट्रांगली इनकरेज करते हैं कि एंटीबायोटिक को स्टॉप कर दे। इस तरह अगर आपका जो बेस लाइन प्रोकैल है अगर उससे 80% डिक्रीज हुआ लेकिन फिर भी आपका प्रोकैल का जो लेवल है 0.25 और 0.5 के बीच में, तो फिर भी वो जो गाइडलाइंस आपको इनकरेज करती है कि आप एंटीबायोटिक को स्टॉप कर दें। फिर तीसरा सिनेरियो इस तरह है कि अगर आपका जो प्रोकैल बेस लाइन से 80% डिक्रीज हुआ है।
Raziella, I think so. We are running out of time. I will move on to the question which have been asked, if you don't mind. Would that be okay?
Yeah, okay. बस ये वैसे आखिरी स्लाइड है मेरा।
All right. Thank you. Thank you very much for sharing the slides, and I will move on to the questions. One question which has been asked by Rehan Anjum is you mentioned DDDs. It's with the Kashif. You mentioned DDDs in your presentation, but it couldn't be implemented in the PICU. Did you advise any other metric to monitor the use of antibiotics in the PICU?
Yes, we can use days of therapy in PICU, which we also did in our pilot project, which we did in PICU, right? The difference between DDT in days of therapy is that DDT is only designed for adults. The dose is fixed for the adults, but the dose for pediatric is not fixed. We have to give a milligram per kg. So that's why DDT cannot be used for the pediatric population. ठीक है ना? And there are two different, what should I say? In DDT, we use patient days. In days of therapy, we use present patient days. So there's a difference. पेशेंट डेज का मतलब ये होता है कि कोई भी आप दिन का एक टाइम फिक्स कर लेते हो। फॉर एग्जांपल रात के 12 बजे आईसीयू के अंदर 12 बेड्स ऑक्यूपाई थे, तो योर पेशेंट डेज विल बी 12। लेकिन पेशेंट डेज प्रेजेंट के अंदर ये होता है कि अगर आपके पास आपने एक टाइम फिक्स किया रात के 12 बजे, तो उन 12 बेड्स पर जितनी रोटेशन उन 24 घंटे में हुई है वो आपने सब काउंट करना होता है। कौन सा पेशेंट एक्सपायर होकर नया आया, कौन सा पेशेंट ट्रांसफर होकर, सो देयर This is the major difference between DDT and days of therapy. और यहाँ पर हम इन दो को different रखते हैं, days present और patient days. So we do use days of therapy in the pediatric population, not the DDT.
Okay, fine. Point well taken. Another question is with Dr. Sadiq from Indus. Would you comment on the use of antibiotics given IV state versus IV infusion over 30 to 60 minutes? As we know, most of the antibiotics in most of the are being given IV.
Well, I think he's talking about regarding the extended infusion of antimicrobial. There are different pharmacodynamic parameters of the antimicrobials. Some antimicrobials are concentration dependent, some are time dependent. And mostly we use the beta-lactam antimicrobials, which are the time-dependent antimicrobials. So as far as we give over the extended period of time, for example, 3 or 4 periods, the time more than MIC should be more than 40%. And in some cases, we do require the T more than MIC for around 60 to 70%. So by doing so, we can also prevent or we can also prevent the resistance pattern like this. Okay, ठीक है ना? इसमें होता क्या है कि आप अगर एंटीबायोटिक कोई एक्सटेंडेड पीरियड ऑफ टाइम में देते हो तो उसका एक स्टेडी स्टेट अचीव हो जाता है, ठीक है ना? फॉर एग्जांपल आपने एक एंटीबायोटिक दिया, वो फर्स्ट आवर में ऊपर चला गया और फिर नीचे आपने MIC जो है सी मिन पर आना शुरू हो गया, मिनिमम कंसेंट्रेशन आना शुरू हो गया, ठीक है? जहां पर आना शुरू हुआ, फॉर एग्जांपल 8 आवर पे आना शुरू हो गया, आपने 8 आवर पर वहां से आपने उसको जो है एक एक्सटेंडेड इन्फ्यूजन स्टार्ट कर दिया, तो जो कि स्टेडी स्टेट में फिर मुस्तकिल उस टी मिन से सी मिन से वो हमेशा ऊपर रहेगा. एज अ रिजल्ट आपको टी और MIC जो है वो मोर देन 40% मिनिमम इट इज फॉर टाइम डिपेंडेंट एंटीबायोटिक्स, ठीक है? और जो कंसंट्रेशन डिपेंडेंट होती है लाइक फ्लोरोक्विनोलॉन्स हैं, लाइक कोलिस्टिन है, तो वहां इस एक्सटेंडेड इन्फ्यूजन की आपको जरूरत नहीं पड़ती.
Got it. Thank you very much. We'll move on to the another question. I think so it's regarding the challenges in implementing the antibiotic stewardship program with the lack of interdepartmental coordination. I think so. Kashif, you can share your experience, and then we will move on to the panelists for that.
Initially, we faced challenges in getting the compliance, in getting कि हमारे physician जो है हमारी intervention accept करे. Then we decided that I personally go into their QICs, into their meetings and presenting their compliance data. Your department is getting this compliance and our benchmark is like this and this. So then they do ask different questions, like as Dr. Ikram also said, फिर के हमारी इस तरह जो है मकसद ये स्टीवर्डशिप कौन चला रहा है, आप लोगों का चेयर कौन है, और जो है इस तरह से मकसद ये तो हमारी प्रिस्क्राइबिंग पावर आप खत्म कर देंगे कि हर 3 दिन के बाद जो हम आईडी को कंसल्ट देते फिरेंगे. Then I told them, sir, this is not necessary कि आप ID consult every 72 hours दें. If you can write the rationale of using this antibiotic in one line, and if this rationale is well and good, then we would mark it as a compliant. लेकिन अब अगर आप रैशनल भी नहीं लिख रहे हो अपने उस हमारी इंटरवेंशन के नीचे और आईडी को भी कॉल नहीं करो, देन इट विल बी मार्क्ड एज अ नॉन कंप्लायंट. सो मैंने जो उनकी क्वेश्चंस में जाके उनको डेटा प्रेजेंट किया, एंड देन द आवर कंप्लायंस गेट्स लिटिल बिट बूस्ट.
Okay.
So it is very necessary to communicate or to communicate the compliance with the relative departments as well. और आज हमारे 2 साल हो गए, 3 साल हो गए, और अभी तक जो मैं उनकी QICs में जाता हूँ, उनको डेटा प्रेजेंट करता हूँ अभी तक जाके जो है कि आपकी कंप्लायंस इतना है, आपका कंप्लायंस इतना है.
Dr. Ram, do you want to add anything on that? Okay, Palab, do we have any other question?
No, I think we have answered all the questions which were posted in the chat box.
All right, I would like to. Yeah, I think so. That was a great session. Thank you very much, Kashif. And I would like to thank all the panelists who have been there and taken out time for this session. It was a great learning opportunity for everyone. And we will going to we're going to have another session next week, most likely on 23rd of February on sepsis phenotypes. As a continuation of this masterclass series, we're gonna share the Zoom link as well as YouTube link for that soon. Thank you very much. Take care and stay safe. We'll see you soon.
Thank you, Rafi.
Thank you.
Thank you, guys. Assalamu alaikum.
Walaikum
Salam.
salam.